Good afternoon, everyone. Thank you for joining us today. My name is Melanie Paris, and I'm the Senior Director of Health Initiatives and Education here at the American Kidney Fund. Based on your feedback that we received, we're doing this webinar on living kidney donation and everything you need to know. Before I turn the presentation over to today's speaker, I'd like to direct your attention to the control panel you see on your screens. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the section of your control panel titled Questions. We'll see your questions and we'll do our best to answer them either by replying to you in the questions box or out loud during the last several minutes of the presentation. This webinar is being recorded and will be made available for viewing on our website, kidneyfund.org/webinars, within the next 1 to 2 weeks. For those of you in attendance who are health professionals, we're glad you joined us today and hope you'll recommend this webinar to the patients you work with. However, as a friendly reminder, this webinar is not accredited for continuing education. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. So without further ado, let me introduce today's speaker, Dr. Keith Melanson. Dr. Melanson is currently the director of the George Washington Transplant Institute as the medical director of the Ron and Joy Paul Kidney Center at George Washington University Medical School. Dr. Melanson is a professor of surgery whose specialties include kidney, pancreas, and liver transplantation, as well as kidney donor nephrectomy. His research interests have centered upon increasing access to health care for minority patients, particularly in the field of organ transplantation. Dr. Melanson has spent his career trying to improve outcomes for the hardest to transplant patients and therefore has been an advocate for ABO-incompatible organ transplantation, paired kidney exchanges, and immune system desensitization strategies. Recently, Dr. Melanson and his team were the first ever to perform a fully ABO-incompatible deceased donor transplantation, as well as a fully ABO-incompatible living donor kidney transplantation in an individual with HIV infection. He hopes that the novel immunosuppressant protocols that organ transplants will begin to last for the lifetime of the patient and that true transplant tolerance can be achieved in the near future. Dr. Melanson, thank you for joining us.
It is my pleasure. I'm very happy to be here talking about live kidney donation and transplantation because honestly, it's one of my favorite things to participate in. Well, as we get started, I like to let everyone know exactly why kidney transplantation is of the utmost importance to people who have kidney disease. And the scenario I like to give to my students is if you take a room with 100 people in it and you have a mirror image of that room. So in room number 2, you have another 100 people or patients. And if you put the people in room 1 on hemodialysis, so all these patients have kidney disease. You put them all on hemodialysis, and then you put the patients in room 2, and you give them all kidney transplants, and then you fast forward to 10 years later, there is a vast difference in survival. The patients who are on dialysis for those 10 years, the average sort of dialysis patients in this country, only about 20% of those patients are going to still be alive compared to about 70% of the patients who got kidney transplantation. So kidney transplantation is not just about getting off of dialysis or a better lifestyle. It is about survival. So people who donate their kidneys either before death or after death are actually saving people's lives. That is the first thing that everyone needs to understand. Let's go to the next slide. Okay, so now we're going to talk about being a live kidney donor. There are lots of myths out there, so we're going to just carefully go through all of the things that I've heard throughout the years and what the actual facts are. First of all, a living kidney donor will usually be in the hospital for about a week or longer after surgery. That is just not true. The way that live donation is currently done in this country, a person who donates their kidney will have what's called a laparoscopic procedure, tiny little incisions done with the special instruments that allow minimally invasive surgery. These patients do very, very well and are usually in the hospital no more than 2 days and nights. So that is the truth. People are only in the hospital a very short period of time. Next slide. Okay, people often wonder, what are the changes that live donors have to do with their diets or in their behavior after they give up a kidney? And the fact is, you don't have to change your diet or habits at all. People often ask about alcohol. You can drink alcohol after you donate a kidney. You can eat pretty much whatever you ate prior to donating the kidney. I will tell you, we usually want people to stop smoking if they were smokers, but even in that scenario, if you would like to, you could go back to smoking afterwards. But the truth is that there are no dietary restrictions after kidney donation. A kidney donor can eat anything they would like, but like everyone, should follow a healthy and well-balanced diet. Next slide. Okay, so this is a fact that I think people in the country don't know but should know. And the fact is that lots of people in this country have chronic kidney disease. In the United States, there are 30 million people, or about 1 in 7, have chronic kidney disease. One of the things that I have dedicated my life to is getting out into the community and explaining to people what are the precursors to kidney disease. And the precursors are primarily diabetes and high blood pressure, as well as obesity. These are the things that you and everyone needs to be working to try to avoid or to fix in order to decrease your risk of kidney disease. It is an epidemic in this country currently. Next slide. Okay, renal replacement therapy. Once you have end-stage renal disease, so not chronic kidney disease. Chronic kidney disease just means that your kidneys are not functioning at their best, but you're not sick enough to require renal replacement therapy. Renal replacement therapy is reserved for people who have end-stage renal disease. There are about 1 million people in this country who have end-stage renal disease. People with end-stage renal disease can only survive if they are receiving some sort of renal replacement therapy. And that is either dialysis, which could be hemodialysis, or peritoneal dialysis, or kidney transplantation. As we discussed earlier, the mortality and morbidity, the death rate and the disease rate is about 4 to 5 times higher with dialysis when compared to kidney transplantation. Next slide. So transplantation, this is one of my favorite lithographs, and it's a chimera out of Greek mythology. All patients who receive a transplant are chimeric, meaning they are a mixture of whoever donated their organ and the patient. I've had patients tell me that their taste change, that they start to like different things because the person who donates to you, their cells go throughout your body. So the chimera is the symbol for the American Society of Transplant Surgery for that reason. Next slide. So for a transplant, this is a common question that I get. Do you have to have your kidneys removed, or where does the new kidney go? And it goes in a little bit of a different location than the kidneys you were born with. We make an incision on the abdomen and we place the kidney deep inside the abdominal cavity, but not in exactly the same location where the kidneys are that you were born with. And you do not, usually, you do not have to have the kidneys that you were born with removed. Next slide. Why transplantation? Well, there are over 100,000 patients on the kidney list, and we only do somewhere between 17 and 20,000 transplants per year. So there's a great demand for organs. Of those 17,000 kidney transplants that are done per year, about 10,000 are from deceased donor, which means we do about 7,000 to 8,000 from live donors. We would not be able to meet the need, and we're currently not totally meeting the need, but there's no way we would meet the need for the number of people who need transplants by just doing deceased donor kidney transplants. We desperately need more live donors. Live donors save lives. Next slide. So the types of kidney transplantation are either going to be from a deceased donor, someone needs to die, and they have to die in a very specific way in order to be a kidney donor. What most people don't understand is only about 1% of people that die in the United States are going to die in such a way that they would be able to donate their kidneys. So that's why you will never have enough deceased donors to supply the entire nation. Live donor kidney transplantation is actually the best type of transplantation simply because the operation is done in an elective fashion. The donor can go through all of these myriad tests before they donate. We can find out everything about the donor. The donor has to be in excellent condition to be able to donate a kidney. And when those kidneys are donated, they tend to last a lot longer. They have a much lower chance of complication. Next slide. So the donor operation, as I stated earlier, that operation is done laparoscopically with the tiny little incisions, and the patients usually tolerate the operation very well, and the hospital stay is very short, only 1 to 2 days. Next slide. Okay, true or false? A living kidney donor is usually in pain for 3 to 4 months after surgery, and that's just not true. Most living kidney donors, as I stated earlier, will go home within 48 hours. Now, they're not back to normal within 48 hours. It takes a couple of weeks before they get back to normal, but they leave the hospital within 48 hours. They obviously can have pain. Usually the pain comes from gas that we have to inject into their abdomen in order to do the operation. They get some bloating, their colon, they can, it's like being a colicky baby. You can have some pain from your colon contracting. But again, these things are usually self-limited and resolved within 3 to 4 days. Next slide. A living kidney donor must be the same age as the recipient. That is not true at all. Transplants can work very well even when there is an age difference between the donor and recipient. There are all sorts of ways that people can not be exactly the same, but still be very good donors. One of the things that people ask me is about, does it have to be a family member? Does it have to be someone of the same ethnicity? None of these things are true. We can work with almost anyone who is a good surgical candidate when they're trying to donate. Next slide. The survival rates in 2 groups, and what I'm showing here is that the 5 and 10-year survival for deceased donor kidney transplant is 86%, 5 years, 46.7. About half of the kidneys are still working well at 10 years. That's deceased donor, but look at the difference for live donor. 5 years is 93%. 10 year is still at 89%. So the whole point here is if you were to be able to pick what type of kidney transplant you would want to receive, by far the better option is to have a live donor kidney transplantation. Next slide. True or false? A living kidney donor can't be older than 60 years of age. That is just not true. A living kidney donor can be older than 60 years of age, and as long as they are a good surgical candidate and they don't have things like diabetes or obesity, people at all ages can be donors. Now, you do have to be an adult. You have to be greater than 18 years of age. You have to be 18 or older. But anyone at any age can possibly be a live kidney donor. Next slide. Living donor surgery. Donors are selected after a very long procedure of a workup. Now, it can be done in weeks or even as little as a month, but it is a rigorous procedure to choose an appropriate donor. The procedure is well standardized. It's done laparoscopically. The incisions are small. As I stated earlier, the patients are in the hospital only 1 to 3 days, and there's considerably less pain with this procedure than the old-fashioned operation that was done before laparoscopic donor nephrectomy. Laparoscopic donor nephrectomy has been the standard of care since the mid-1990s. Prior to that, people had to have a large incision on their abdomen. Many times a rib had to be removed in order to get the kidney out safely, and the patients had a lot more pain. This is not the case with the modern operation. Most people are back to work and totally return to normal activities within 4 to 6 weeks. Patients who have white-collar jobs or desk jobs can usually get back to work even sooner than that. Next slide. What are the risks? Well, there are real risks in any major operation, and being a live donor is a major operation. So therefore, the risk would be pain, bleeding, infection. All of the normal post-surgical complications can occur. And depending on the patient, some people need a longer time to recover. But the risk of any major complication, major morbidity, or death is very, very small. 0.03% risk of death. That's about 1 in 10,000 operations. That makes this operation one of the safest operations done in the world today. Next slide. What happens after surgery? Well, the quality of life of a living donor is comparable to an average adult with 2 kidneys. I tell you, I always tell my living donors as well as their families and lay people that after donating your kidney, for these people, I think their quality of life is even better. These are the sort of individuals who gain a lot of pleasure from helping others. Otherwise, they would never have done such an altruistic sort of thing. So these people actually, I believe, fare better after they donate. Donor in great condition health-wise is going to sail through this process, and the operation, although like any major operation, is going to lay them up for a few weeks. After that, these people do very, very well. Next slide. Okay, true or false? A living donor can no longer play sports or exercise. Again, not true. Quite famously, there have been living donors who've gone on to play professional sports, be it basketball, football, etc. So you definitely can go back to your normal lifestyle after donating a kidney. A kidney donor should be able to return to regular activities, including sports and exercise, in about 4 to 6 weeks after surgery. Next slide. A living donor can no longer drink alcohol after surgery. Again, not true. A kidney donor can drink alcohol, and we say here in moderation because everybody should be drinking no more than in moderation. Now, what I will always tell my live donors is that after you donate your kidney, when one of your kidneys is removed for transplantation, the kidney that remains will compensate. And one of the compensatory mechanisms that the kidney utilizes is actually to increase the blood flow through the kidney. And what this does is it causes you to make more urine than you did prior to the operation. So donors are at a risk of dehydration, and therefore they need to drink a lot more fluid, particularly water, and dehydrating liquids like coffee or things that contain caffeine or alcohol can actually start to dehydrate them. So donors need to be mindful of that. But in general, donors can drink alcohol in moderation, just like all normal people. Next slide. A kidney donor has to take medications for the rest of their lives. Again, just not true. Kidney donors usually have to never have to add any medications. Now, I will tell you, one of the risks in donating your kidney, particularly if you are borderline for having high blood pressure, is that some patients need high blood pressure after they donate their kidneys. Depending on the population, you're talking about 10 to 15% of people who are kidney donors. So if you do develop high blood pressure after you donate your kidney, you would have to take medication. But for most patients, they're only going to need stool softeners and pain medicine for a short period of time. They will need no other medications. Next slide. Insurance coverage. So follow-up care, anything to do with the operation, the workup and the follow-up is all covered via the recipient's insurance. So nothing from the donor or their insurance would need to be accessed for the hospitalization or the workup or the postoperative care. Okay? Now, just like any person in this country, you would want your patients to have insurance for their own needs thereafter. But anything associated with donating a kidney is covered via the recipient's insurance. Next slide. What's not covered by recipient's insurance? Well, currently, travel expenses, housing or hotel for donors, food, lost wages, cost of childcare, these things are not usually covered. Now, there are special government-associated quasi-governmental agencies that the donor can apply to if they are experiencing financial hardship in order to be a donor. And if they qualify, they can have additional monies that can go to these expenses. But typically, these expenses would not be covered by the recipient's insurance. Next slide. This is a very important and very common question that I get from donors or prospective donors. Can you become pregnant after donating your kidney, and is it safe? And the answer is, indeed, you can become pregnant. It is very safe. Although I tell all young women who are donating their kidneys that it is imperative that they are followed by a high-risk obstetricianist after they donate their kidneys. And the reason is whenever a woman is pregnant, it puts stress on her kidneys. So if she just has one kidney, there's a little bit more stress placed on that kidney when the woman is pregnant. However, this can well be followed by a high-risk OB-gynecologist, and a normal pregnancy is almost always the result. But there are slightly increased risks of pregnancy after kidney donation from a young woman, but the risks are very small. Next slide. True or false? A kidney donor's sex life is negatively affected by donation. Actually, this is not true for the majority of people. There's really not an impact on your sex life, albeit, it's going to take some time for you to heal to the point that you can participate in safely in sexual activity. But your sexual libido will not be affected by donation. Next slide. A female kidney donor cannot get pregnant after donation. I think I approached that earlier, but that is just not true. A female donor can get pregnant after donation, although the donor should wait about 3 to 6 months after donation to become pregnant, and this is only because the body needs time to recover from such a major operation. Next slide. Okay, so I told you earlier about the fact that we in this country are struggling to get people transplanted simply because we don't have enough kidneys. So we always have to come up with novel ways to increase our transplant rates. We do what's called paired kidney exchanges. And this is very important when you start talking about live donors, because it is possible that someone would want to donate a kidney to a loved one or a friend, and for some reason they don't match. We match people up by blood types. We match them up by these proteins that everyone has in their blood. They're called human leukocyte antigens. And if you don't match up well, sometimes it's not capable. Sometimes we are not capable of taking the kidney from the person that wants to donate and giving it to the recipient that they would like to donate to. In that scenario, what we can do is what's called a paired kidney exchange, where that person who would want to donate can donate to another recipient that they are compatible with, and then that other recipient's donor can donate to their recipient. That's called a paired exchange. The other thing that we can do is we can do these ABO incompatible transplants. And all that means is you could have a different blood type, an incompatible blood type, and we can still do the transplant. Now, this is not just like people having different blood types, but they're compatible. Like someone who is blood type A can get a kidney or blood from someone who's blood type O. Even though they're different blood types, they are compatible. But vice versa is not compatible. So someone that's blood type B could not donate blood or a kidney to someone that's blood type O, at least not typically. There are things that we can do, and this is something I've spent my career doing. There are different medications we can give to people to make it so that they could receive an organ for someone who is a different blood type. These are novel strategies to increase the transplant rate because we're up against the wall in trying to do what we can for our patients with end-stage renal disease. Next slide. So this is what a paired exchange can look like. In the purple example there, that's a two-way exchange, and it works exactly like I said for an incompatible group 1 and incompatible group 2, they simply switch donors. In a three-way paired exchange, what happens is it's exactly like the two-way, except that there's an additional couple, and that additional couple allows 3 transplants to happen. In these chains, what can happen, and we have done many of them, is that you could have what's called a non-directed donor. Someone just comes in and says, you know what, I want to donate my kidney. I don't care who it goes to, but God has told me to do something good for mankind. These beautiful people, we call them non-directed donors. They come in, and oftentimes they can set off a chain reaction. That's why we call it a domino paired exchange. So this chain reaction occurs because they donate to someone, and we try to have them donate to someone who had a donor, but the donor wasn't a good fit for them. And then their donor is freed up to donate to another person, and this can go on. And that's how chains occur. You may have seen in the media that sometimes these chains go on for years, and dozens of patients can get transplanted in this fashion. Next slide. Here at the George Washington Transplant Institute, we have paired kidney exchange and non-directed or altruistic kidney donation, and they are always times of great celebration, and that's what you're seeing depicted in the photographs here. We absolutely love all of our patients, but of course, the donors that come forward, particularly when they just want to save someone's life that they're not even associated or had been associated with, it's a time for great celebration. Next slide. Okay, true or false? A kidney donor and recipient must be related by blood. Just not true. Actually, most of the transplants done for a live donor in this country, the people are not related by blood. So a donor and recipient don't have to be related by blood. People can donate to family members, friends, or even strangers. Next slide. A living kidney donor has to be the same blood type as the recipient. Like I said earlier, you can be a different blood type and still be compatible, or you could be a different blood type and be incompatible. Even if incompatible, there are centers around the country, albeit a small minority of transplant centers, but there are centers around the country, including ours, where even if you have different blood types and otherwise you match up well, you can undergo transplantation. Next slide. Yeah, I just wanted to show you, this is a recent poster that we presented at a major conference. And what we showed in this poster was that we could do ABO incompatible transplants, not just with live donors, but also with deceased donors. We are trying everything, and it's not just here at GW, but throughout the country, transplant programs are trying to do everything in their power to try to increase the transplant rate in this country because people are dying awaiting transplantation. Next slide. So what are some of the ways we have adopted to increase the awareness and access to healthcare in terms of kidney disease? Well, here at our program, and again, this has been replicated throughout the country, it all starts with outreach. Outreach is important because you want to reach people exactly where they are in their communities, in their churches, in their leisurely time. You want to interact with people and let them know that they need to have this on their radar. What is their overall health? What is their kidney health? Education is of the utmost importance. You know, one of the things that frequently happens to us as we outreach into the community and try to educate people is just the vast amount of ignorance that people have about kidney disease, and in particularly the antecedents of kidney disease. To give you an example, many people think that just because they're seeing a doctor, just because they're taking medications, that even though they've been diagnosed with something like high blood pressure or diabetes, just for the fact that they're seeing a doctor and getting medication, they are fine. And that's just not true. Nothing could be further from the truth. What needs to happen is the problem needs to be fixed on a daily basis. So if you have high blood pressure, not only do you need to be taking medicine, but your high blood pressure must be resolved. You must have normal blood pressure in order not to be at risk for the problems that high blood pressure can elicit, like stroke, heart attack, kidney disease. What is normal? Normal means a top number, systolic blood pressure, 140 or lower. The lower number, diastolic blood pressure, 85 or lower. That's normal. If you're not normal, then it needs to be addressed. Same thing with diabetes. You must get your blood sugar normal. What's normal? A fasting blood sugar less than 120. If it's higher than that, you still have diabetes. It must be treated. we do kidney screening programs, one of the things we really like to do in our screening is check for protein in someone's urine. If you have protein in your urine, it's a very cheap, quick test that can be done. If you have protein in your urine, that's abnormal and must be worked up. The reason we like to do that test when we screen people is because if you have protein in your urine, that can be an early sign of kidney disease. And when you have early kidney disease, it can be fixed by fixing the problem that leads to the kidney disease. To give you a common scenario, let's say you have protein in your urine, your creatinine, your blood test is normal, but you have a lot of protein in your urine. Well, what we figure out is that you have early kidney disease. You already have CKD, chronic kidney disease. Well, let's say this is occurring to you because you have high blood pressure. Well, if you now get your blood pressure under control and it continues to be under control with new medications, then the proteinuria can go away. The kidney disease can go away. Okay, so that's why the screening programs are so important. Dialysis outreach is very important because people on dialysis need to know all of their options. They need to know about in-center dialysis, nocturnal, meaning going to the dialysis center at night. They need to know about home dialysis, either peritoneal dialysis or hemodialysis at home. And then they need to know about transplant, live donor, deceased donor. People that have end-stage renal disease need to have access to the best information, and that's why dialysis outreach is important. Health fairs and social media outreach are other means of that we utilize to reach people, but the goal is always the same: to maximize the education of the populace about their health care options. Next slide. Okay, so what you are seeing here is, at least at our program, some of the things that we have done in the community to alert people about kidney disease and educate them about their options. It's one of the proudest things that I can say about my program is that we have made it our mission to help many other great organizations like the American Kidney Fund and others to get out into the community, screen people, and educate them about kidney disease. Next slide. Yeah, my favorites, and I must admit my bias. My favorites are our live donors. This is a collage of people who have donated their kidneys to help someone else. Some of these people donated to their loved ones. Some people donated to their friends. A few people up here were what we call non-directed donors. They decided to donate to help someone that they didn't even know at the time. We are so proud to be aligned with these phenomenal humans. They make our lives richer. Next slide. So these are the conversations you need to have with your doctor about kidney screening. If you have protein in your urine, that is the earliest predictor of kidney disease. I've had so many people tell us that we have found protein in their urine in a screening. They've gone and they've talked to the healthcare professional, and the healthcare professional said, "Oh, it's no big deal." Let me be blatantly honest, blunt here. This is a huge deal. If you have protein in urine and your doctor's ignoring it, you need to get another doctor, because unless it is being addressed, you will develop more kidney disease, and it needs to be addressed forthwith. Blood pressure check. It's like what I was saying earlier. Most of the people that we see when we go out and do screenings and find that they have high blood pressure, we find out that they are already under the care of a doctor or a healthcare professional, which is not good. If your blood pressure continues to be high, even under treatment, then the treatment needs to be changed. at our center, we have screened over 1,200 people for kidney disease in the Washington, D.C. metropolitan area. And I can tell you that about 25% of the people that we see wind up getting diagnosed with some sort of kidney disease. So it is very prevalent in our area. It's very prevalent throughout the country. And like I said earlier, what is important is the follow-up. So when we screen people and we find that they have a problem, we definitely immediately get them enrolled in our program, and they go to see a doctor to have the problem followed up upon. That's very, very important. Next slide. So anyone can be a donor if you pass the screening, but it is very important that we get people to donate either before death or even after death. One donor after death can give 8 life-saving organs. And they could also give tissues, corneas, and these things are very important to save lives. Donation is very important. Next slide. Okay, that was pretty short and sweet, but I hope that I covered everything that about live donation, and I'm open to any questions. I hope that there are great questions coming from the audience.
Well, thank you, Dr. Melanson, for just leading this wonderful webinar, and we did receive quite a few questions during the course of the webinar. So I will get started right away. So one question we received is the following. It says, will trouble controlling my blood pressure disqualify me from donating?
It's a very good question. So we have changed over the years, and now we do allow people with high blood pressure to donate their kidneys. It depends on the center, but at my center, I can tell you we definitely allow people to donate even though they may have high blood pressure. What is key, however, is the blood pressure must be well controlled. And it is best if the blood pressure is well controlled with just one medication or maybe 2 medications. If your blood pressure can be well controlled with 2 medications and you're otherwise fine, then you can be a kidney donor. The problem would be if you need very high dosages of medicines or if you need more than 2 medications, then you may not qualify to be a donor. But if it can be controlled with 1 or 2 medications, absolutely, you could still be a live kidney donor.
Okay. Another is, I was told that after donation, I have to cut down on my protein intake. Is that true?
Another very good question. And the answer is that although natural protein, so through food like lean meats or vegetables, almost any amount is going to be fine if you're active and drink lots of water. Usually what we want people to cut down upon if they're taking a lot of is supplements. So if you're taking a lot of protein supplements like protein drinks or some other sort of supplements, then that is something we would like to minimize right after donation. Now, with time, we will allow people to increase their supplements if they are adamant about taking them. But what we want to happen, which occurs with everyone after they donate their kidney, the kidney that remains enlarges a little bit and becomes more efficient, but it takes time. So we wouldn't want you to stress it with too much protein supplements in the first few months. Over time, you can start to increase the supplements. However, we would want to monitor your kidney function and the amount of protein you are spilling in your urine. You know, not all of us are created equal. If you are an athlete and you do a lot of working out and you're otherwise healthy, you can tolerate more protein than a normal person. So these things would have to be monitored, and usually we still allow people to have some supplements, and they can increase them slowly over time.
Okay, thank you. So here's another one, Dr. Melancon. It said, I've heard anecdotally that donors may deal with chronic fatigue or mental health trouble after donation. Have you heard about this? Is that true?
Yes, both of those things have happened to certain individuals after they have donated. However, statistically, you're speaking about a sliver of the population. Most donors do not deal with either one of those problems. It can happen. Let's deal with the chronic fatigue first. So your kidneys are, besides being a great filter for your body, also secrete a hormone which is called erythropoietin. And when you give up one of your kidneys, you can have less erythropoietin production for a period of time, and it can make you a little anemic. When you're anemic, it can cause you to have fatigue. As long as you have a healthy donor that goes back to a healthy lifestyle, that amount of erythropoietin should increase with time, and the fatigue should go away. Now, there is going to be a very small percentage of people that may deal with chronic fatigue, but again, you're talking about a sliver of the population. If that occurs, then these people need to be followed by medical professionals, and that would have to be addressed. And because what really happened in that scenario is that the donation triggered what probably was going to be a chronic issue for that person later in life. Mental health issues, yes, these have occurred after donation, which is why the screening process is of the utmost importance. Every single one of our live kidney donors sees a social worker who's trained in identifying any antecedents of mental health diseases. And if there's any clue that there might be an issue there, we send these patients on to a psychiatrist. But even when properly screened after donation, people can have mental health issues, particularly if the recipient of their kidney did not do well. This is a known problem in the field of live kidney donation, and that's why we go in with both eyes open, and we will follow people very closely after their donation. And if any of these sorts of issues creep up, they are dealt with forthwith by the transplant department. And again, if you have any issues that directly deal with you being a kidney donor, it is all covered via the recipient's insurance. So in the insurance coverage would not be an issue. But yes, these things can happen, but they are very rare.
Okay, thank you. So picking up on that insurance issue, we have a question about that. Can someone who doesn't have insurance donate?
Very good question. And this is something we deal with quite often, unfortunately. And the answer is yes. You can donate even if you do not have insurance, although we would prefer that you did, just because we want our donors to have the best care after donation and for the rest of their lives. Because, having one kidney, albeit not a health problem, you can go on and have a totally normal life after that. Years later, and I'm talking 5, 10, 15, 20 years, there are things that can happen in life that would increase your health risk because you have donated a kidney. Let me give you an example. Let's say you donate when you're 30 years old, and then 25 years later, when you're 55 years old, over time you've gained weight, you have become a type 2 diabetic. Well, these are problems for any person because it will increase your risk of kidney disease, but particularly for a person who has one kidney. So it would be much better if you, all those years later, had insurance and was seeing a doctor regularly. In our area, in transplantation, we have increased our follow-up of donors, but it's not nearly long enough to capture all of the things that happen in life decades after donation. We only follow donors very closely for about 2 years. That gives us enough time to catch any issue that's directly related to the donation or anything that crops up in the year or so afterwards. But obviously, it's not going to allow us to capture everything. So we would want people to have access to health insurance, but you do not absolutely have to in order to be a donor unless you have health issues beyond what is typical for a person trying to donate. To give you an example, if you have a chronic problem, it's not something that would disqualify you from being a donor, but you need to take your medicines and you don't have insurance. That's going to be a problem pre-transplant, and it would be hard to get someone like that cleared to be a kidney donor.
Okay, thanks for clarifying that. So there is another question as well. It's kind of related to that. It's what happens if a donor needs help medically after surgery and the recipient drops or changes their insurance?
Another very good question. And what usually happens, and I can only speak for my program, the donor is going to be indemnified by the transplant program. So even in the scenario where the recipient's insurance is not up to date or what have you, if there was an expense and it should have been covered by the recipient's insurance, and for some reason the recipient's insurance does not cover it, then the transplant center, through Medicare funding, because Medicare actually gives money to transplant centers to increase transplant rates. So the federal government, via the transplant center, will make sure that that donor is made whole. If this is something that would have been covered by the recipient's insurance, and for whatever reason the recipient does not have insurance to cover it, the transplant center will cover it.
Okay, so let's transition a little bit into some other questions not related to insurance. So another one that we received is, what is the possibility of a live donor dealing with IRC after donation?
Dealing with what? IRC?
Yes.
I am not sure what the IRC.
I'm not sure either, but that's what we received, so. Oh, okay. Well,
I don't know what that acronym stands for, so I can go a couple different ways, but I don't know what they mean by IRC.
Well, I think I'll table that one, do some research, and then we can maybe revisit that question a little bit. So another one that we received is someone's interested in donating to their wife and has AB type blood. She is not. He's interested in a paired exchange, but is wondering if the pool will be limited because of the AB blood type.
It's a very good question. And yeah, it is a little bit tougher for a person who is AB blood type to donate because it's such a rare blood type. And the person that receives that kidney, to be perfectly aligned, would also have to have AB blood type. What is the more common scenario for that person would be to donate to someone who can receive an ABO incompatible transplant. And in that scenario, it would be a person with the O blood type, but they have what we call low titers to A or B. Or it could be someone with a B blood type and has low titers to A. But even if they have to find someone with the exact same blood type, it can be done successfully if they are otherwise healthy. What's going to be more of an issue is how easy it's going to be to find the right match for his wife. But either way, it can be done.
Okay, one question, what is the possibility of a live donor experiencing chronic kidney disease after they've donated?
Again, a very good question. And the statistic that we most often quote would be, the number is about 5 in 10,000. 5 and 10,000 people after they donate would have kidney disease related to the donation. So it is possible, but it is extremely unlikely simply because of the screening process. So we screen people very carefully to make sure that they are going to be in the best kidney health possible prior to donation and after donation. The other thing that's important in the people that have gone on to develop kidney disease, when we looked at this over time, what we found was that these people usually develop a problem that could have been dealt with early, and had it been dealt with, they probably would not have gone on to kidney disease. So what I'm talking about are things like high blood pressure or diabetes, which again, it's not that developing high blood pressure necessarily pushes you immediately into kidney disease, but if you develop these sort of chronic problems after donation, they must be dealt with to decrease the chance that you could go on to kidney disease. I'm proud to say that in this country, the transplant community has done an excellent job in following donors and making sure that this rate of kidney disease after donation is extremely low, but it's not zero. So there is a chance, albeit very, very low.
Okay, we have time for just a couple more questions, so I'll get to them quickly. One, what is the success rate for second-time transplant recipients? And another one, which is interesting, I know there's been press around it, are you seeing more organ availability as a result of the opioid crisis?
Okay, so I'll deal with the second one first. And yes, the rate of donation has gone up as a result of the sad opioid crisis that we have in this country. And there are therefore more deceased donor transplants as a result of that. So yes, the numbers have gone up, and it is unfortunate. And you know, the other unfortunate thing is that so many of these donors are young. The good news is that families that are dealing with these horrible, horrible tragedies are able to look through their grief and try to help others. So yes, unfortunately, the opioid crisis has led to more donors. The success rate for second-time recipients is actually pretty good. You know, it now on the transplant list, approximately 20 to 25% of the people that are on that list are coming back for another transplant. They experience the life-saving opportunity of having a transplant, and many times it's years ago, but their original transplant's not working, and they have to come back for another one. Those patients actually do very well, particularly if they're getting transplanted the second time with a live donor. But the success is really good, and that's why we do offer people a second transplant, even after they've undergone this procedure before.
Okay, thank you. So I think I have time for one more to squeeze in if we can quickly. Is rejection more common in polycystic kidney disease?
Another great question. I tell you, you've had great questions today. And no, actually, people with polycystic kidney disease are some of our healthiest recipients, and they actually have excellent outcomes, including having low rates of rejection. The patient population we have the most problems with are going to be the diabetics overall. And then as far as rejection, it's going to be people that have had prior transplants or people that are what we call sensitized. These are people that, like women that have had babies, usually numerous babies, or people that have had blood transfusions in their past. But polycystic kidney disease, these are among the healthiest people to get transplanted, usually because their kidney function is preserved for a long time, even after they develop chronic kidney disease. So when they get transplanted, because they have residual kidney function, if their kidneys had not had to be removed, they tend to do very well, including having low rejection rates.
Thank you so much, Dr. Melanson. I wish that we had time for all of the questions that we received, but maybe we can ask you offline and post the answers to some of the questions that we received that we didn't get to at this time. But I want to thank you again for leading an excellent webinar. It was very interesting and very informative to our audience, so thank you so much. Just to note, this concludes our webinar, and we will have another webinar in May. More information and registration will be posted on our website about that webinar at kidneyfund.org/webinar. When this webinar closes, please do not close your browser window. You may see a pop-up saying that the webinar has ended. Please close that pop-up and proceed to the webinar evaluation survey. Your honest feedback will help us make our webinar program the best it can be. Thank you so much again for joining us, and we hope to see you in May.